Hi, welcome to you. Thank you so much for joining us on today's Zoom meeting. Our topic of discussion for today is diagnosis and management of colorectal cancer in the era of COVID-19. I am Yemisi Adeyeye, the MD of Life and Hospital, and we have two amazing speakers today. The first speaker is Dr. Ademola Adeyeye. He is an European board certified surgical oncologist. And our second speaker is Mr. Sanjay Chowdhury. He is a general and colorectal surgeon with the University Hospitals of Leicester, NHIS Trust, UK. He is also an entrepreneur and a former flight pilot with the Indian Air Force. He's also someone who has a very soft spot for Nigeria and Nigerians, having lived in Nigeria in the early 70s. So after now, the voice you hear is that of Dr. Ademola Adeyeye, followed by Mr. Chowdhury. Thank you so much.
Right. Good day, everybody. I'd like to welcome us all to this Zoom webinar. Special thanks to Mr. Sanjay Chowdhury for taking time out of his busy schedule to be part of this meeting. He is the main speaker, but I will just be giving a rundown of the Nigerian perspective to this. So I do not have any disclosures. I'll be talking about the diagnosis and management of colorectal cancer in the era of COVID-19 with the Nigerian perspective to it. So I'll follow this outline in terms of some case presentations. I will highlight certain issues of colorectal cancer, such as the cause, clinical presentation, care from a Nigerian perspective, and some challenges. Then we'll talk about some COVID-19 peculiarities, and I'll conclude. So the first case is a 42-year-old female who was seen on the 19th of September 2017, who referred from the gynae clinic on account of fecal discharge from the vagina over a month's duration, and there was a preceding history of bleeding per rectum, tenesmus, and mucoid stools. The other sorts of issues were not contributory. So the antibodies included following EUA and endoscopy showed a mass in the arising from the posterior wall of the vagina, and at endoscopy we saw a rectal tumor which seemed to have breached the rectovaginal septum, and so we diagnosed tentative diagnosis of a vaginal fistula was made. Abdominal scan done then showed locoregional disease, which was staged as T4, N1, and N0, and other investigations were normal. However, we didn't have access to an MRI to stage this patient appropriately. So the patient subsequently had a laparoscopy-assisted divided segment colostomy and biopsies of the rectum and the vagina. The colostomy was to divide feces away from the vagina, and we could see as part of the laparoscopy staging to see if there's any evidence of peritoneal disease or liver metastasis. Peritoneum appeared clean, and there was no evidence of superficial liver metastasis. And so these images here showed stages of the laparoscopic procedure, including bringing out the sigmoid colon through the anterior abdominal wall. And then this is the final divided colostomy that's been fashioned for this patient. So this already came out as a mucinous rectal adenocarcinoma. And then chemotherapy, chemoradiotherapy was actually the preferred modality for this patient in the neoadjuvant setting, but we don't have access to radiotherapy for this patient. And so we ended up giving 6 cycles of K-pox, in which there was a 50% regression of the rectal mass. And in February of the following year, she had an abdominoperineal excision of the rectum and a posterior vaginectomy and a vaginoplasty, all under general anesthesia. And then following the perineal and abdominal dissections, we're able to bring out the rectosigmoid specimen with the posterior vaginal wall, and this is the final TME specimen for the patient. We're able to reconstruct the posterior vaginal wall and also close up the perineal wound. The specimen result came out as a moderately penetrated rectal tumor involving the anterior rectal wall and extending to the posterior vaginal wall and the anal canal. The margins were said to be free, but we had no comment on the TME status or lymph nodes or lymphovascular innervation. Unfortunately, she defaulted follow-up and presented in March, about 13 months following the APL, with complaint of bleeding from the new vagina of 5 weeks in duration. EUA then revealed a 2 cm local recurrence at the posterior vagina adjacent to the introitus, and she didn't have any form for CT scan or MRI to appropriately stage whether this was actually local recurrence or there was any systemic disease. But abdominal ultrasound scan and chest X-ray were said to be normal. So she eventually had a local excision of the recurrent site, evidence area of recurrence, and this was eventually reconstructed. Now the questions were that should we follow up with adjuvant radiotherapy or give chemoradiotherapy or radiochemotherapy. Unfortunately, while this was being decided follow up and has not been seen since the middle of last year. Second case is that of a 7-year-old male who was seen on the 1st of April 2017 with a complaint of epigastric pain of a month's duration. And there were no other significant modifying factor, and there were no alarm symptoms, neither there were any lower GI symptoms. He had no comorbidities or previous surgery, and his family and society were not contributory. General examination revealed an ill-defined vague epigastric mass. His lab results were normal. There was no mass seen on the mucosa of the endoscopy, and the gastric biopsy then showed gastritis. However, his abdominal scan showed an exophytic mass arising from the greater coverage of the stomach with evidence of metastasis on the liver. And we treated this as possible metastatic gastrointestinal stromal tumor. So at surgery, laparoscopy, we confirmed the presence of the exophytic gastric mass, as well as the evidence of the liver metastasis. This family had a wedge excision of the stomach, including the mass, and a liver biopsy. However, we had a shocking surgery report. While the stomach confirmed that he had a high-grade gastrointestinal stromal tumor, which was positive for c-KIT and vimentin, the liver biopsy showed a metastatic mucinous adenocarcinoma of gastrointestinal origin. So the questions were that we had an incomplete diagnosis. What was the primary status of adenocarcinoma? We had to get a second opinion of pathology, which confirmed the initial review. And we had to look at the initial CT scan and consider that we had missed a lesion at laparotomy. And if this was actually true, it would mean that this patient had dual malignancy. And what were the implications of this for surgical, and systemic therapy? So the review of the CT scan showed then that there was actually a suspicious lesion in the cecum that was not reported at the initial CT scan review. And a repeat scan done after the surgery showed a definite cecal hole tumor. So we reviewed the diagnosis, haven't done colonoscopy that showed that there was actually a cecal hole tumor. And our diagnosis for this patient was a high-grade GIST with a metastatic right colonic carcinoma. So if someone had a right hemicolectomy and a leucolic anastomosis, and this is a picture of the cecal hole tumor with the specimen. And the histology showed the well-represented mucinous adenocarcinoma, which was staged as T3N1MX, which fell out of 12 lymph nodes positive with lymphovascular invasion, but they were free margins. He had 6 courses of K-pox and daily imatinib, and liver disease was said to be stable. However, he developed bilateral pleural effusion in March 2018, which was about 11 months post-gastric surgery and 9 months post the colon surgery, for which a closed tube tracheostomy drainage was done. He declined second-line chemotherapy and defaulted follow-up. He, however, died on the 21st of April 2018, 1 year after the gastric surgery and 10 months after the colonic surgery. The third and final case is from the COVID-19 era, where we recently saw a 6-year-old female who had complained of left iliac fossa pain and change in bowel habit. There was a papal mass in the left iliac fossa, and the abdominal scan showed a sigmoid colon tumor, which was staged as T4N2 and M0. We did not do a colonoscopy because of the COVID-19 protocols. The RT-PCR sum of the patient came out negative. The chest CT scan was normal too, and the system technique showed lack of COVID-19-like symptoms in the preceding 2 weeks to surgery. She subsequently had a segment colectomy and a colorectal anastomosis under epidural anesthesia. Our typical protocol for this patient pre-COVID would have been to do general anesthesia, but because of the risk of urogenic procedures, we are now doing more epidural anesthesias for laparotomy. She did well following Sarah's protocol, where the surgery time was about 5 minutes. There was a second day post-op, and I moved well by the third day post-op. She was discharged on the 4th day post-op, and we planned for more procedures on the 10th day post-op. The pathology came out recently as a moderate carcinoma with free margins and a positive lymph nodes, and she's awaiting chemotherapy. Now, in terms of etiology of colorectal cancer, just as a public awareness message here, most of it is idiopathic, but we know that age above the age of 40 years, family history and genetics, and reduced dietary fiber and high fats are likely risk factors. In addition to that, people with inflammatory bowel disease, previous colon cancer, polyposis syndromes, or adenomas are also at high risk of having colorectal cancer. Clinical features depend on location of tumor, the mode of presentation, and extent of disease, whether it's local or metastatic. And brain media presents electively or as an emergency. Majority of patients typically present as elective cases, whereas a quarter of them come as emergencies. The elective presentation could be as simple as A, B, C, D, E, where we talk about the case of malignancy, asthenia, anorexia, and anemia, the bleeding from body orifices, such as the rectal bleeding, change in bowel habits, discomfort in the abdomen, and expanding abdominal mass. If brain comes as emergency, it could come with any of the 4 Bs of blockage, which refers to obstruction, either the GI tract, the ureter, or the bladder, or bleeding for massive GI hemorrhage, perforation when the mucosa bursts, or a breach like the first case presentation. We mentioned that location could well be based on goals determined presentation, where we know that right colon tumors tend to bleed and cause a mass, left colon tumors tend to cause obstruction and change in bowel habits, and proximal and third tumors tend to cause intestinal obstruction, especially sigmoid. Middle and third tumors tend to cause tenesmus, and distal and third tumors tend to cause bleeding, mucus, and mass or incontinence. And for these patients, we must always do rectal examination. Now, because of time, I want to talk about the stage-based features so that I can move on. The largest and probably most robust series of prospective series of patients who had colorectal cancer in Nigeria was published in 2019 by the African Society for Oncology. And in this study, there were about 300 patients from from 5 Nigerian hospitals who were seen over a 40-month period. And rectal cancer and right colon tumors were the commonest presentations. Majority of the patients had stage 3 or stage 4 disease. And only one patient had stage 1 disease, unfortunately. And there was a general lack of compliance with treatment. Poverty was quite prevalent because the average income of the respondents were about 20,000 naira or $55 US. Most of the patients had either a right colectomy or a colostomy, and overall survival was mainly predetermined by the type of treatment the patient had. So those who had overall for all the patients, or for those who needed chemotherapy, as seen in this graph below, the median survival for those who did not have chemotherapy was about 26 months, which was quite significant statistically. Now in the COVID-19 era, a lot of things have changed, and we know that Nigeria is still experiencing a high incidence of coronavirus infection. The number of cases have doubled in the last 1 month, and we still appear to be in the phase 4 of the pandemic, just before the peak. We have a case fatality of 2% as at the last review. So the principles of mitigation, such as wearing a mask, washing your hands, and washing your space, don't need to over labor on that again. They are very important social measures that we can take in mitigating the spread of the virus. But in terms of colorectal cancer diagnosis, we have issues because screening and diagnosis will be impaired in this scenario. We are not able to do endoscopies because endoscopy are required as an aerosol urinating procedures, especially colonoscopy. And so we are not able to appropriately get endoscopy assessment before operating on these patients. And we're not able to screen those who are at high risk of having the disease. Now, there are some novel things that we've been trying out as a study group, or they're not allowed to talk about the details. We know that we've been trying to do a urine-based study where we can detect metabolites secreted by the tumor in the urine that can detect or can suggest the presence of colorectal cancer in an individual. And we've identified at least 3 metabolites in the urine that can predict 85% certainty that the patient has colorectal cancer or an adematous polyp. And this may be a game changer in selecting those who actually benefit from colonoscopy and not. Another thing we can do is actually to use simplified models to selectively screen our patients. There are those who have symptoms such as asthenia, weight loss, bleeding per rectum, or change in bowel habits, have an 7.5% chance of having colorectal cancer. So this patient may actually be stratified in terms of diagnosis and appropriate treatment. Now, in terms of the cancer surgery considerations, we know that we have to consider the triad of priority of the surgery, the vulnerability of the patient, and the environment in which the patient is being managed. And we know that patients who are quite frail and elderly are more at risk of developing mortality if they develop coronavirus infection. Now, the typical cancer pathway that is recommended, we try to apply for the third patient where we make sure that they don't have symptoms of coronavirus within 14 days of surgery and had an RT-PCR swab. Recently, some centers are doing antibody testing now in order to determine obtain an environment, unlike in other times. We of course do surgery based on different protocols. And ultimately, we consider post-operative care using the ERAS protocol and telemedicine for follow-up, and immediate isolation for at least 14 days. Now, various colleges in the UK have brought out guidance on how to approach patients with colorectal cancer. And as at this review, then patients were not being subjected to endoscopy because of risk of aerosol generation in that procedure. Also, laparoscopy too has been shelved in many centers, and that's probably applicable in an environment where this procedure was not even done routinely. So, on my own personal experience, I've seen a slight increase in endoscopies, about 25%, but I know that many public hospitals are not doing endoscopies in this era. But there's been a 40% reduction in colorectal cancer referrals because patients are probably getting diagnosed but not coming to hospital because of fear of acquiring infection or for other reasons too. The number of patients that are coming for emergency have remained fairly stable, but elective surgeries for colorectal cancer have reduced drastically, and this is a source of concern in our environment. We know that in terms of chemotherapy, the patients who have severe adverse effects from chemotherapy and have coronavirus infection have a 14% increased chance of mortality. And that's why we have to consider a lot of issues in this patient, including use of oral agents that have less immunosuppressive tendencies. And one popular drug is capecitabine or Zelodaf, trade name, which has less side effect compared to other conventional chemotherapy agents. Because of time, I will not dwell more on the issues of chemotherapy in the setting of neoadjuvant, adjuvant, and palliative. Mr. Child will talk more about that, but I also have to mention it for sake of completeness. So in conclusion, colorectal cancer is increasing in incidence in countries like Nigeria, and it requires early detection and treatment. Delayed and misdiagnosis, socioeconomic challenges, and a weak healthcare system are major obstacles in managing patients in our setting, and the era of COVID-19 has produced unique challenges. So I'll take questions later on, or I'll stop sharing my slides so that Mr. Chowdhury can continue the rest of the presentation. Thank you for listening.
It is almost the center of England. It's in the eastern part of the Midlands. It's famous for its football team. Of course, we didn't do so well this year. Fifth is not bad. Leicester is also famous for a very big Indian population, and we have one of the biggest Diwali celebrations. In terms of the hospitals, we have 3 large hospitals. This is my hospital, and this is the oldest part of my hospital. You can see here, it was built in 1905. Times are moving on, and this is one of the sites called the Leicester Royal Infirmary, and we're hoping that this hospital of mine will look more like this in a few years' time. We'll have a maternity hospital. This is again newer buildings, so thanks to the government, we've got 428 million apparently to start building a much better and a newer hospital. In terms of a unit, we are one of the biggest colorectal units in the country. And for those of you who are familiar with what we have called the National Bowel Cancer Audit, this is an audit done by NHS England through the Association of Surgeons every year, and they publish outcomes for the entire country. And this is the most recent audit from last year. It covers a 5-year period from 2013 to 2018. This is all the hospitals in England. This is my hospital there, and you can see we are one of the largest centers for colorectal cancer. Now, as you're all aware, our lives were turned upside down this year. If anyone asked me or asked any one of you last year whether we would be wearing masks and walking around like zombies, I don't think we'd have ever dreamt of that. In the UK, we were slightly late going into lockdown, and I think maybe we were waiting for someone. But the WHO declared a pandemic on the 11th of March, and it was only after we went into lockdown that all our challenges started. We stopped all elective colorectal surgery. In fact, all elective surgeries, so all elective colorectal cancer surgery was suspended. And the idea was that we needed to make sure that we had enough ventilator beds. We decided that anyone having an operation will have to be prioritized as per system. And basically, we were all waiting for Superman to come and help us. Nothing happened, so we started lockdown. What did lockdown mean? Lockdown meant that we told everyone to stay at home. We said that this was needed to protect lives. We said this was needed to protect the NHS from being overfilled. And the worry really was that while we wanted to stop spread of the disease, we'd heard stories in northern Italy, in Spain, where hospitals didn't have enough ventilators. Patients were struggling to find a ventilator to be put on. So what NHS England decided that we would convert all our theatres, the ventilators in them, to sort of ventilated bed spaces. The government started building these Nightingale hospitals in large conference centers. This is the one in London. Unfortunately, while we started all this hoping that this was a great idea, we never really needed it. And most of these big hospitals in London, Birmingham, Manchester were never really used. So that was about trying to create capacity. Now, what did we do with patients who needed an operation? We said, okay, we're going to prioritize you. If you're an emergency, you are a priority 1A or a 1B, and these patients will jump. So every day we would sit and decide that, okay, who has how many patients, what priority are they, and then we would offer them surgery or decide who gets to go to theater. So the idea was that you were priority 1A if you needed surgery within 24 hours to save life. You were priority level 1B with a 3-day thing. So anyone who was obstructed, bleeding, etc., on this basis, we would sit and share the limited theater space. Now, priority 2 patients were patients, I'm reverting to colorectal cancer. These were patients who were having elective surgery, and we said that these patients, we cannot delay their surgery to more than 4 weeks because we might lose the opportunity to cure them. And then we had priority 3 patients where we said, okay, these patients can be delayed for up to 10 to 12 weeks without, we think, any problem with their outcome. So if a patient had had long course chemoradiotherapy and was waiting for rectal cancer surgery, that would be priority 3. If you had someone who had a large transverse colon tumor where you thought this patient is likely to obstruct, soon we would say, okay, there is no evidence of obstruction now, but this should be a priority 2 patient because we should go ahead and operate on them sooner rather than later. And obviously, if someone obstructed, that would be a priority 1B. So that was the way we try to work our way through a mismatch of capacity and demand. And this was about patients who had cancers. Now, the problem was, what about patients being referred? Eddie talked about the fact that there's been a reduction in patients who've actually come and seen people. Now, the problem we had is with people staying at home, we were told we can't bring them to hospital. So we decided that anyone who was referred, we would get on the phone or use the video link and call them up, talk to them about their symptoms and try and figure out whether these patients needed to be seen or could have a test to help us diagnose whether they have colorectal cancer or not. So we decided that only the ones who were genuinely urgent, those patients would be invited to come to hospital. In the UK, we have a bowel cancer screening program, which is based on FIT. So we decided if people have a FIT more than 10, between 10 and 20, anyone more than 20 should definitely have a CT scan. If it's between 10 and 20, depending on resource, we made a note of these patients and said that, okay, whenever we have capacity, we will try and do a CT scan and see. The problem was that colonoscopy stopped at the start of lockdown. Everyone started to worry and panic about the fact, is this aerosol generating? And colonoscopy practically disappeared. The other thing that happened is very quickly, people came up with this. This is a colleague of mine from Birmingham, Anil Bhangu, who is from a hospital not far from mine. And they came up with this cohort study where people collaborated and done an audit of patients who had surgery between January the 1st and March 31st. They had 1,128 patients, and they were trying to see whether patients who underwent emergency and elective surgery, how many of them had COVID, what was the effect of COVID on their outcome. So essentially, I'll talk you through this. They included almost 1,200 patients in their study, and they realized that patients who had pulmonary complications, the mortality rate was 38%. If they had no lung complications, mortality rate was 8.7%. There was some for which data was missing. And again, when they looked at the deaths, people with pneumonias, with acute respiratory distress, people requiring unexpected ventilation, you can see how high the mortality is. And this was 30-day mortality. So all of a sudden, it sent the alarm bells through doctors, through patients, because you said, hang on, if I'm going to go and operate on my patient and their normal elective mortality of, say, between 2 and 10% is going to jump 4 times or 5 times, what am I doing? And again, if you look at this, this is a breakup. So if you see that there was not so much of a difference for minor surgery, whether it was elective, but if you look at emergency major surgery, particularly for males, there was a significant difference in people above 30 years, people less than 70 years. So again, unlike places like Africa, where patients are a lot younger, most of my colorectal cancer patients are in their 70s and 80s. So for us, the big worry was that look at this minor emergency surgery, 30% mortality, right? Elective surgery, again, look at how high the mortality was. So this study published in the Lancet really worried everyone. So this is a summary slide, and we use this to try and explain to patients that, you know, if we have a preoperative diagnosis, you know, how did we diagnose it? It was either done preoperatively based on a CT or a clinical diagnosis. And when we looked at it, people undergoing surgery, 24% of them had COVID or a COVID diagnosis compared to 75 or 76%. If you look at the 30-day mortality, 24%. If you look at lung complications, 50%, right? So that told us all that, listen, we are in a situation where post-op complications are much higher, and we should try and avoid surgery wherever possible. The other thing that I said to you was that our bowel cancer screening stopped. All symptomatic, BSG stands for the British Society of Gastroenterology. They control endoscopy in this country. So they said that, okay, they're going to stop all bowel cancer screening colonoscopy, even if you're FIT positive. They're going to stop all routine referrals. All patients who are at 55 who have flexible sigmoidoscopy will stop. All surveillance will stop. Everything effectively, including outpatient rigid sigmoidoscopy. So we were suddenly faced with a situation where endoscopy was just not possible. Also, there was some confusion about whether laparoscopy is an aerosol generating procedure, and at the start of it, there was a lot of conversation. We have 11 colorectal surgeons in my hospital. We have 6 upper GI surgeons, 6 HPB surgeons, and we all sort of had a lot of debate and discussion, and we said, okay, we're not going to do laparoscopic surgery because the messages coming to us from different places were quite confusing, and we wanted to be safe. Also, we said maybe patients should not have a primary anastomosis, try and keep surgery as simple and safe. So we decided we would not join people. Anyone who had an asymptomatic cancer, we said, okay, this is category priority 3. These patients can wait. And we will reassess them every couple of weeks or as and when they develop problems. In terms of neoadjuvant treatments or adjuvant treatments, the oncologists were very quick to turn around and tell us that patients will not get long course chemoradiotherapy. They will be offered only short course chemoradiotherapy. So they got 5 into 5, which is 25 gray. Also, patients who had T2N0 disease, who normally would have gone straight to surgery. These patients, we discussed them at the MDT, which was done remotely by webinars or by kind of Zoom consultations. And we said that these patients will be offered radiotherapy first rather than surgery. Likewise, any patient who was 70 plus, even if they have stage 3 disease, we spoke to them about the risks of chemotherapy and said, okay, you're only having surgery alone and no further treatment. So this was the impact of COVID on surgery, COVID on adjuvant treatment, COVID on investigations. COVID also had an impact on patients because patients who had problems, who were brave enough to see their doctors, found that there were no tests being done. Patients were scared to go to their doctors. Doctors were scared to run clinics. Patients did not want to come into hospital at all. They were all worried about coming into hospital and picking up the COVID bug. Surgery was being deferred, and patients were not going to get, patients were getting radiotherapy, and patients were getting, were not getting post-op chemotherapy. So that was the impact of lockdown on patients. And for me, basically, it was all to do with, number one, a lack of knowledge about this virus. We were still panicking and trying to get our heads around it. Number two, we had a problem with resource. We didn't have enough resource. The NHS works, roughly speaking, at about 90% capacity. We have no capacity in the system to be able to take, we struggle every year with the winter flu. And this was like, the super flu. Also, COVID had a big impact on staff. You found that the government came up with a list of 1.5 million people. I was one of them because of treatment I'm on. For psoriatic arthropathy, I was advised to stay at home for 3 months. There were quite a few people who worked in hospitals who were on, who were getting chemotherapy, who were on steroids, patients with COPD, people with severe asthma, people from, Black and other minorities. People were really worried about, their well-being. A lot of staff refused to come into hospital because of concerns about, not a lot, but a small number of staff. People were worried, did we have enough PPE? Because at the start, there were problems. And all of a sudden, we realized that from having 9 all-day lists for colorectal surgery, we were down to competing for 3 or 4 lists where we had to go with our patients and say, this man is priority 1, this is 1B, this is 2, this patient can wait. And the entire system became very inefficient. All day, normally, we would, in a list from 8 to 5, we would do 2 major cases. We suddenly realized we were doing 1 case a day, and that too was finishing at 6, 7 o'clock in the evening. Now, again, as we know, with every pandemic, the WHO talks about phases. You talk about, phase where it's few human infections. You start off with, in phases 1 to 3. Phases 5 to 6 are when you get widespread human infection. And now I think we're all in a phase where you can debate whether we are post-peak or whether we're post-pandemic. And the worry is, I would say we are at post-peak with little outbreaks in different parts with spreads, and we're all learning how to best deal with it. Now, what has happened is various people have put together fairly good criteria or have worked to try and help how best to take things further. So these are BSG guidelines for endoscopy, because now endoscopy is back started. They've said that, okay, we will do endoscopy depending on, telephoning people. People are told that, in the last 14 days, have the patients had any symptoms of COVID? Have they come into contact with anyone with COVID? Does the patient's occupation, or have the patient come from a high-risk area where, they could have been exposed to COVID? Is the patient shielded? And then based on that, if they have none of these criteria, you have no testing, you can do endoscopy with level 2 PPE. If you have testing available, you try and do a swab, and then you can decide that if the swab is negative, you then can go on to endoscopy. If the swab is positive, then you need to assess them and make sure that, this has to be level 1 with a COVID minimized pathway. So people have worked out various pathways. Now, if patients have criteria, the question is, can you defer endoscopy for 14 days? Can we do something different? We have capacity for video capsule, okay, in some patients, but maybe not for everyone. So for me, the key bit would be if people are positive based on this telephone criteria, you can then say, hang on, we need to defer things. So this is how we've now taken that on board with trying to plan endoscopy. And I think this might be useful for you to work with your endoscopists and say that, okay, how do we restart endoscopy? This is again talking about, this is a slide from NICE. It's trying to sort of give information to patients about, number one, general information, telling people about, COVID, how it might impact on their treatment. What do you do before care? What do you do regarding prevention and control during care, etc. So there's a lot of guidance that's come out. And you might argue maybe this is too much of guidance, but I guess guidance is useful. And, most people have taken this board, and in a system like the NHS, where things are totally protocol driven, we've had to step back and wait for people like NICE, NHS England, Public Health England to try and tell us what we are doing, why we are doing, and whether you agree with it or not, you need to comply with it. The biggest problem is that all this has had a big impact on our capacity. So at this point in time, we are working with almost like our hands tied behind our back. We have a situation where after the patient is put to sleep, because it's an aerosol generating procedure, there has to be a 20-minute cooling period. This is in spite of patients having been tested now we have a good testing system. People get swabbed 48 hours before to check whether they're COVID, they get the RNA PCR swab done. And we know that, you need 5 air changes, which takes about 20 minutes. We need more staff because we have staff inside the theater who stay there and another team outside who add as a link. So, our capacity, our turnover, plus trying to tell a patient that, listen, you need to come in for surgery and we can only give you a date after you've self-isolated for 2 weeks. It's difficult, particularly for elective surgery, where, someone might have been shielding or someone might have been in lockdown for 3 months and now he goes back to work and he can't because, he needs to shield for 2 weeks. Or someone in his family, might put him at risk of being in the high risk category for exposure. The good news is that, sorry, as I said to you, people are coming in all the time. And NICE has recently, last week, said that, we need to be slightly more careful if people are being swabbed before their operation, elective operation, then maybe they don't need to, have a 2-week process. So they've said that, you can look at just social distancing, good hand hygiene. And if you've done a test for within 3 days, and once you start your test, you then self-isolate, that's a lot better. Now, again, it's difficult because if you ask someone, what is self-isolation and what is comprehensive social distancing, you can get into a lot of debate. But I think at the end of the day, you've got to sit and probably try and be sensible. Some types of surgery, okay, you could argue that, people are elderly, high risk, maybe those patients should self-isolate for 2 weeks. What does that mean for me? That means for me that this is what, things look like as of now. Things are changing. COVID, I think, things, I was sitting and trying to think about what exactly has COVID done to our colorectal cancer pathways. And at the start, I thought it made a big impact, but actually the impact has all been due to problems with lack of resources. Because yes, if you look at it, it's made an impact on patients' consent. You need to now consent patients for, what they're having done, the impact of COVID. It's made us tailor our treatments depending on what phase of pandemic you're in, what are the patient risk factors. But most important, I think, in every hospital, in every country, people have had to sit down and work out what resources are there and how best can you sit and manage them. I'm not sure, as I said, that, COVID has really made a big difference to what we are doing. Yes, it stretched resources. And I think for each one of you, depending on what kind of a setup you have, you will think about, what are you doing? What do you need to change? Certainly, I think moving on. Previously, I was never a great believer of remote consulting. However, because I was shielding for 2 months in April and May, I saw about 250 patients, mostly over a video link, where I did clinic consultations, spoke to them, asked them what was wrong with them, decided if they needed tests. And I was surprised because, number one, I enjoyed it. Number two, patients enjoyed being able to see someone. You can see their facial expressions. If clinics don't run late, even if they do run late, people are still quite comfortable in their house. It's improved consenting because I think it's made one sit and think a lot more about, risks and the risk-benefit ratio of the procedure they're having. So I think this will probably be a legacy whereby moving on, I think I might have one face-to-face clinic every week and maybe one follow-up clinic and maybe surgical triage clinic where I will just ring patients and speak to them and see whether they need to come or not. Now, obviously, if you have to examine someone's rectum, then you do need to see them and, put your finger in. But I think for a lot of patients at the stage where you're triaging their symptoms, you're deciding what tests they need, you can do that and save resource. If you look at the actual pathway, I'm just trying to talk you through. So if you look at patients who are coming in, they're having surgery, whether colon, whether post-op, I don't think the COVID, the current pandemic has really made a difference over here. Yes, it's made a difference when it comes to post-op adjuvant treatment, and that there's no doubt, particularly if you're in a high-risk group, and depending on where you are, it's going to make a difference. Likewise, this is looking at patients with metastatic disease. And again, in patients with metastatic disease, if they're elderly, where normally they would have got some kind of potential treatment, that it has made a difference too. However, this was something which was very interesting. I don't know how much of you are aware of this Rapido trial. And this was something that started a few years ago, where people thought that, instead of giving long course chemoradiotherapy, why don't we run a trial randomizing patients to 5x5 short course vis-a-vis, 25 days long course. And we used some of the early data to look at our patients or to manage our patients. And I've recently scoped a patient yesterday, day before, who's had a complete clinical response following short course for a T3N1 tumor. So we know from this paper that, compliance with post-op chemotherapy is poor. And in these patients, when they looked at short course, there was more toxicity. but there was no difference in details of surgical procedures that people have. And what we're hoping is that as this data matures, we will find that we'll be able to see whether long-term survival for patients who had short course chemoradiotherapy, was that similar? Is that something we should be changing? Because if you imagine, particularly in countries where resource is an issue, if you have to give someone 5 days of chemoradiotherapy compared to 25 days, you can treat 5 times more patients. So I think that is certainly a very big factor for even countries in the first world where resources are always under pressure. Number two, people have talked about studies where this is looking at NICE guidelines, and they've said that maybe people should get only 3 months chemotherapy for stage 3 colorectal cancer, whether it's colon or rectum. So rather than give patients full chemotherapy for 6 months, now again you can see you're much more likely to get compliance from patients. It's going to be probably more affordable. But I think these are things which the pandemic might encourage us, or certainly, whereas previously we never gave anyone these kind of treatments, we're certainly doing that now. So I think the virus is here to stay. I don't think we're going to be seeing the end of the virus by the end of the year. I think it's something that we're going to have to adapt to. And I would want you all to go away and work out, pathways for patients who are COVID positive, patients who are COVID negative, patients who come in as an emergency and we don't know what's happening. My hospital, I've done some work and I've stolen these slides from a couple of colleagues of mine where they put this together saying that what our theater pathway is going to look like. And these pathways, as I said, are specific to whether the patient is negative, unknown, or positive. And again, I can talk you through that, a negative patient comes to a negative COVID ward, goes to a negative COVID theater, and then you make sure that, the areas are all COVID negative. You have someone who's unknown COVID status, you need to make sure that they have specific areas. And at any stage, if you find that they change, you obviously move them into other pathways. Likewise, for patients who are COVID positive, it's important that you have a designated theater for COVID positive cases, or you do them at a normal theater at the end of the case. You need to make sure that PPE is all relevant. You need to make sure that your recovery areas are separate. And to be honest with you, we've done quite well, because I was looking at the number of patients who picked up COVID when they came in negative in my trust during the peak in April. It was less than 15%, which I thought was quite good. Now, again, there's a lot of debate of what is an aerosol generating procedure. And I think for us, we started off by thinking that lower GI endoscopy was. I don't think lower GI endoscopy is. I was initially quite anxious and nervous about restarting endoscopy, as I myself am an endoscopist. But now, the more I've thought about it, I don't think lower GI endoscopy is an issue. Upper GI, yes. There is a risk with upper GI, but I don't think any of our colorectal procedures come into this category. Also, I think it's very important. My trust have just gone and come up with a special consent form that we need to talk about, whereby, the risks of COVID. So this needs to go on to their consent form. They also get a booklet where, they see, which gives them a bit more information, because patients are scared. I think we need to look at, this is going to be a legacy, and, we're probably going to end up cleaning our hands. Probably, gone are those days when you would hug and shake hands with everyone you saw. Today, you might have to sort of from a distance, sort of give them a high five or sort of lift your hand. We need to make sure that, areas are clean. I think masks, unfortunately, are here to stay. And whilst, I'm not quite sure of how effective There's a lot of debate about it, and people have been changing. But I think masks are definitely here to stay. And poor Donald Trump too has had to, agree with that. So with that, I come to the end of my presentation to the
Thank you
host.
so much, Mr. Chaudhry, for the beautiful presentation. And I want to say thank you to Dr. Ademola Adeyeye for his own presentation too, in ourselves and also learning new ways of doing things. And I want to say to the participants, thank you so much for being part of this. I would like to hand over to Dr. Ademola Adeyeye to moderate the question and answer time. Thank you.
Thank you very much for the moderation, Dr. Adeyeye. I'd like to thank Mr. Chowdhury again for this wonderful presentation. I think we've learned quite a lot. I personally have learned quite a lot from the experience you've gathered over the last couple of months. And the fight with COVID, the mnemonic was quite interesting to see. And I think a lot of people have lots of things to take away. I'm sure we'll look forward to the recordings and so that we can review what you discussed. There are a number of questions in the chat group, which I'll take question quickly before asking my own questions too that I had in mind. So there's a question in the chat to say, for those patients who have had to go for radiotherapy or neoadjuvant chemotherapy instead of surgery when they had early cancers, who bears the cost of radiotherapy and neoadjuvant chemotherapy? Probably bearing in mind the fact that these modalities of treatment may be more expensive, especially radiotherapy, than surgery. So will the patient, in your setting, will the patient still have to pay out of extra, or will the NHS cover for that? And then there's a question, I think you addressed it in a way that, how do we determine the risk of aerosol generation in a procedure? Because there's a lot of controversy about that. And then one other comments, I think is directly to you, sir, is there a room for the patients knowing the COVID-19 status of the medical team taking care of them? That while we are screening patients for coronavirus, are we not supposed to screen medical personnel who are treating these patients for coronavirus? And so I think we'll take those questions before we address all the other ones, sir.
So the first thing is, let me start in reverse order. Medical staff, I think, yes, we owe it to our patients to be able to reassure them that, they don't have, that we don't have the virus. And the problem, however, is money. So in Leicester, the private hospital has started helping the NHS. In fact, all private hospitals are helping the NHS. And for me, the private hospitals have dictated that every surgeon who goes to what they call the green zone will have to have a test every 10 days. So effectively, every week I get the nose put up my nose and throat, and someone checks the results. We can get the results now within a day, but I am not allowed to operate there. Now, the private hospital is a very small hospital in the sense that they have 3 theaters and they have about 40 beds. But the cost of swabbing people is about £100,000 a month. Now you can imagine my trust is about 5,000 staff. And when you look at clinical staff to swab everyone so often, I'm afraid, no one's prepared to ask this question. Maybe if the tests got cheaper, we might, or if there was another way, people are talking about saliva-based tests, etc. But I think, yes, the patient has every right to know whether, what precautions are we taking, etc. So I think, the main issue is its cost. Because if you said to me that you have so much of money, are you going to spend it? I would say, first of all, spend it on PPE. Number 2, spend it on, you prioritize your things and then work accordingly. And then at the end, when you get to money, I would rather now, if you said to me that in a hospital, if they could spend money on giving more patients free treatment, that is probably better than spending money on, staff well-being or, so these are difficult debates. But I do think that, yes, it is only a matter of time before someone goes, in the UK, someone goes to court and says, well, why shouldn't all doctors and, the treating team who are looking after me not have a COVID test, particularly, when risk of transmission is high. Now, things will change, because I have a feeling this will, as it dies down, you will come to the winter phase, and, as and when things rise up again, we might have to do that. Maybe in the so-called cold state later on this summer, when the risk of transmission goes down quite low, we might be okay. But I think, yes, this was something which was definitely raised. And the only reason why in our trust, infection control or NHS England haven't done it is because of money. So that's your question on that. Now, in terms of...
Sorry, sir. Just a minute, sir. Because this other question is relevant to what you just said. Somebody sent the question that what is the legal implication of a surgeon who refuses to operate on a COVID positive patient? So the patient has coronavirus infection and he says, I don't want to operate on that patient. Is there any legal implication to that?
Well, I think you would be in front of the General Medical Council, because in the UK, you have a duty of care to your patient. And if you've been given full PPE, now I can understand surgeons refusing to operate on someone without PPE, and that would be accepted. There were some shortages and stories about shortages at the start of the pandemic, because no one expected so much of PPE to be used, and the amount of PPE we waste or we run through every day is boxes and boxes and boxes. And I don't know where is all this going to be buried, because all these will have to be buried somewhere, so, or destroyed. So yes, I don't think medical legally you would be in a serious trouble in the UK if you turn down. It's like, I can't turn down operating on someone if they are HIV positive, as long as I've taken all the precautions, and the precautions that are available and accepted are there. Now, yes, I'll give you my personal example. I am on a drug called Humira. I'm on a drug called methotrexate. I recently was on a course of steroids, so I was told for 3 months to stay at home. Now, when I went back to operating, after 2 months at home, got bored and said, okay, I'm going to go back and operate. I signed a disclaimer, but as long as I have full PPE, and I'm not, so if I'm fit and healthy, and I'm not in that particular high-risk group, which the government decided, for 3 months. So that 3-month period finished at the end of July. So now the virus transmission is so low that the government have said that, listen, you all have to go back to work and just be careful. So I don't think you can refuse to operate on someone, because if someone reported you to the GMC, you would be in trouble. You have a duty of care as a doctor. The other thing you talked about was chemotherapy and neoadjuvant treatments. The beauty of the NHS, amongst all its downsides, is the fact that the patient pays nothing for inpatient treatment. And chemotherapy, even though you get it as an outpatient, the moment you come to hospital as a day case patient, you are not charged a penny. You pay about £9 for a prescription drug. If you don't have a job, you can, but otherwise, all treatments, there is not a penny paid at the point of...
I saw 2 hands raised up. Professor Majid from Pakistan is the president of the Pakistan Society for Surgical Oncology. He raised his hand a while ago, but I can't see him on the participant list. Can the host please unmute him, Professor Majid? Then I think there's Okoyemi Omolola who also has a question, but let's recognize Professor Majid. On the chat, maybe he had some network issues. Hopefully he rejoins. But I think Okoyemi Omolola has a question. His hand is raised. So can the host please unmute Okoyemi Omolola?
So I'll tell you what, I'm running down the questions here, and I can say Charles has asked a question saying, what is the 20-minute cooling between intubation and extubation? So the idea being is that if you don't know the COVID status, when you actually you intubate someone, at that point, there is a chance that droplets and aerosols might be released into the air. And because they've been released into the air, they might settle down on, they're in the air, other people might inhale them. So what we've been following was that patients would come into theater, everyone would clear theater, and only the anesthetic team and the team inside would, with full PPE, intubate the patient. And once they'd intubated the patient, there'd be a 20-minute wait whilst that was taken out of the system before the surgical team could come in. And likewise, when the patient was being sent out after extubation, there was a 20-minute holding period in theater to try and make sure that, any such, because the air change, our hospital theater systems, you need about 5 air changes before the aerosol is cleared completely. Don't ask me how this has been worked out, but this is what was given to us as a directive. Now you could argue that if you know someone is COVID negative and you swabbed them just 3 days or 2 days before, maybe you don't need this, because you will stop wasting 40 minutes between each case.
Thank you so much, sir, for the answer to the question. Dr. Ademolade is trying to come back into the Zoom room.
There's another question there that I'll take.
Can you hear me?
Yeah. Eddie, I'm just going to tackle a question. The finding of COVID-19 in stool samples.
Yes, I'm going to ask that question.
We know that the virus is excreted in stool. And there's been some very interesting research done in, I think, the Netherlands, where they've looked at fecal, sewage levels of the virus and tried to predict the, spread and outbreaks. I think Paris, there's been some work done, and even in the UK, I remember seeing a paper somewhere about it. However, I think when you're doing a colonoscopy, the actual sort of aerosol generation or the amount of sort of leakage that you're going to get, I'm not so convinced that it is truly or at the same level as that from, when you cough for those droplets. So, yes, I appreciate the fact that there is a lot of this research going on, and we know you can get the virus in there. But, people have now stepped back and said, well, okay, low GI colonoscopy isn't. Now, whether they've done it for various other reasons, but even though, some endoscopists at the start refused to do endoscopy, gastroenterologists said that, no, we're not prepared to do that. And BSG were very quick to say, well, stop. But now BSG have stepped back and said, you know what, it isn't as risky as upper GI endoscopy. So yes, I do accept that, and maybe time will.
Thank you, sir. I think there's another question, or there's one more question in the chat room about, well, I think you've spoken about that during the presentation, that you can actually postpone an elective procedure if it is asymptomatic and is COVID positive, so that can be sorted out as long as it's not life-threatening. So I think that had been discussed already. I think we're running out of time. I don't know if you have any other closing comments for us before we go.
Yeah, I would just like to thank all the participants and Ademola for putting together something, to give up time on a Sunday afternoon anywhere, it's, we all work very hard. We have very little free time for ourselves, and to give up family time and come and listen to, something like this. I think well done to you for organizing it, and thank you for everyone for coming and listening to me, and I hope they've got something out of it. And if anyone does need any further information or any of these pathways or any guidance, I'd be very happy to help providing, Eddie, through you. I'm happy to, provide any pathways, any patient information leaflets, etc., protocols, because at the end of the day, we're all people trying to do the best for our patients.
Yeah, thank you, sir. I think Professor Majid is back with us, and his hand is still raised.
Yeah,
Thank you, Ademola. Can you hear me? I'll just take a minute. This is just to thank you for arranging such excellent webinars, and to specially thank Mr. Chaudhary for being here, spending time with us. I represent the Surgical Oncology Society of Pakistan, and I happen to be in charge of surgery and surgical oncology at one of the teaching hospitals, which has been a category green hospital, and we've been operating through the pandemic. Mr. Chaudhary's comments have been very, very useful. And this is the way forward, because I believe that Pakistan is very similar in situation to Nigeria. Although quite unexpectedly, we had expected that the acceleration phase of our pandemic would last till mid-August. But surprisingly, the graphs have started to come, they have started to come down. And we are moving more towards elective and elective. And I think this is the only way that the exchange of knowledge between the developing world and the developed world, and especially the United Kingdom, where Mr. Chaudhary works, we can learn from that, because in Pakistan, we've been implementing and following the intercollegiate guidelines. And especially, I would like to remark, just one small remark for the question, which Dr. Chaudhary has already answered. For the United Kingdom, the rules in Pakistan also are very, very similar. A government teaching hospital consultant or a government sector hospital cannot say no to treating a COVID positive patient. This just cannot happen. However, we have seen a few cases in the private sector where senior consultants who are elderly have refused to operate, but then they have resigned from jobs or they've taken long leave. So that's the way it is. I would like to end my comment by thanking Mr. Sanjay Chaudhary. Thank you very much, sir. And thank you, Dr. Ademola, for...
Thank you so much, our dear presenter, so much to our participants. Thank you for your patience and also learning how we can handle colorectal cancers in this COVID-19 era. Once again, I'm Yemisi Adeyeye, MD Lifehound Hospitals, and we will get back to you soon with another amazing topic relevant for this time. Thank you, and God bless you.